This is the first of 4 videos that will comprise and match with your outline for physical therapy in a variety of pediatric settings. They're just broken up because of the size of the videos. So in this first one we'll go through and we'll start with a neonatal intensive care unit, and that's what the second part will also cover. And then we'll cover birth to 3, and then finally school-based physical therapy in a separate video. Overall, what I want you to think about is the kind of patient problems that you see in these different settings, the goals of physical therapy, and in some cases the interventions. So as I mentioned, we'll start with neonatal intensive care unit, also referred to as the NICU. Patients in this environment, as you can imagine, are pretty high risk. These are infants whose medical problems might cause motor problems, cognitive delay, or other social or interactive deficits. So I want to go through some examples of the types of problems that you might see in a child in the NICU. So there might be lots of reasons why hypoxia occurs to a child, either before or right during or slightly after the birthing process. And that hypoxia, of course, can particularly affect the brain and brain function. So we could have a variety of maternal factors that contribute to this. The umbilical cord might get wrapped around the neck. It might collapse or get compressed. One condition that you might have heard of but might not be familiar with is called placenta previa. And as you can see on the left, the placenta should be more at the top of the uterus. In placenta previa, it's shifted down to the bottom and covers the opening or the neck of the cervix. So a couple of problems here. One is just as the child gets larger, this is going to tend to compress on the placenta layers and maybe on the umbilical cord. But certainly during the birthing process, it's going to be very disruptive and could cause hypoxia during that process. We mentioned earlier that children who are born too early, too premature, don't have mature respiratory systems. And even if they do, their respiratory passages are very small. So respiratory issues are always a big concern and may definitely land a child in the NICU. We talked about CMV before. Intraventricular hemorrhage can be a problem with premature infants within the first week of life. Intraventricular, of course, within the ventricles in the brain. So if there's bleeding into those ventricles, it'll increase pressure in the brain, and that can cause brain damage. Probably also heard of this, baby jaundice, also called hyperbilirubinemia. So hyper meaning excessive or elevated. Bilirubin is the component we're talking about, and emia means it's in the blood. Bilirubin is a component that's created as a byproduct or a metabolic waste product when old red blood cells are kind of broken down and gotten rid of. And the bilirubin has to be broken down also by the liver and then excreted. And in these infants, the liver isn't able to do that. Now this condition generally is pretty self-modifying, so within a week or two, but in the meantime, in order to prevent the bilirubin from reaching toxic levels where it can have really serious impact on the child, the UV lights actually can break down the bilirubin into a component that can be excreted by the kidneys. Viral infections, one example would be HIV. Infants born to a mother who has HIV have about a 30-35% chance of acquiring HIV themselves. So that can range anywhere from 10 to 40%, but about average about 30 or 35% chance. We mentioned alcohol use by the mother when we talked about teratogens. That may result in a child with fetal alcohol syndrome, and that child may need to be in the NICU for a while. Some of the changes, as you can see, the alcohol definitely affected development of the head and the face, and also in some cases the brain. The head and the brain tend to be smaller than normal. We tend to see what's called a flat facial profile. So we see in the upper lip, for example, that little divot that comes down between the nostrils is not really there. The upper lip is very thin. The ears are small and set low on the head. And we typically can see a little fold on the inner angle of the eye. So in this slide on the right, you see a mannequin designed to have these features, and then on the left you see a child with really striking similarity. It definitely kind of shows most of those features on the eyes and the upper lip and the mouth and the face. There are some GI problems. One of them is a type of inflammatory bowel problem called necrotizing enterocolitis, and it, of course, would disrupt or interfere with the child's ability to take in nutrition. There can be visual disorders. We'll talk later when we talk about pathologies about brachial plexus injuries. There can be orthopedic problems like a club foot or a hip dislocation. So a lot of those conditions we'll talk more about, but my point is that there's many wide-ranging conditions for which a child might end up in the NICU. And so as we're thinking about how we would treat that, I guess I skipped neonatal drug withdrawal. Sorry about that. And this is really important because, unfortunately, it's a growing problem again. Some of you may be aware in the 80s and 90s there was a pretty high incidence of babies born to mothers who abused cocaine, and so they were called crack babies. Now, unfortunately, we're seeing a resurgence of babies born to mothers who have overused opiates. So these could be prescription painkillers like Oxycontin or Vicodin, and they could also be heroin or methadone. But essentially, because the mother has taken these opiate medications throughout the pregnancy, the child is born actually addicted to them. So has to go through a long and painful withdrawal process. This is definitely a rise in concern again. There's been an increase from the year 2000, so in about the past 15 years, a five-fold increase in the incidence of babies born with neonatal drug withdrawal. So definitely a concern. So that's the last thing I wanted to bring out, different examples of conditions for which the child might be in the NICU. And as we look at then how we want to approach a child in the NICU, I want to point you to a theory that is explained in your Tecklin book. So hopefully you've read through this, and we'll read through it again. It's called the synactive theory of infant development or behavioral organization. And this is an example of a systems theory, just like you talked about systems theory last semester in neuro. The basis of the systems is the autonomic nervous system, which is the system that's going to create physiological stability. In other words, it's going to regulate heart rate, blood pressure, temperature, respiratory rate, anything you can think of for which we normally want to stay within homeostasis. Motor organization, think about muscle tone as well as normal volitional activity. Behavioral state organization refers to the infant's ability to kind of get into normal sleep-wake cycles. Attention interaction means when they're awake, they have periods of time where they're willing to interact and pay attention to their environment, other times when they're a little more quiet. And then just finally, above all, self-regulation, the ability to regulate themselves as an organism and their interaction with their environment. So we'll talk about how this impacts physical therapy in particular, but when we're looking at children in the NICU, everything should be designed to help promote their ability to regulate themselves. We have to remember that they've prematurely, early, been taken out of that very supportive uterine environment, which, as we've said many times, it was dark, it was quiet, it was warm, it was supported, and now they're into this literally cold and bright and loud world. So we want to make sure that we support their ability to stay self-regulated within this new environment that they're in. And toward the end of this video, there'll be a little video you can link to where practitioners and parents are talking about the NICU and the philosophy behind that. So that'll give you a little bit more. This is just another picture out of your book, and it does talk about the development of the child, and the interaction with the environment. And here's the intrauterine environment, and then the extrauterine environment. So remember, as they're transitioning, here's the isolette, the little place that they'll be. I'll show you a picture of that in a second. And then within all that, development is proceeding. And so the child has to be able to, we want to smoothly couple developmental improvements, changes, with changes in the environment. And so when the child kind of abruptly gets transitioned from one environment to another, and also may have some developmental issues, then that can make it more challenging. So we just are trying to optimize their development. So our goals of physical therapy intervention within this are to normalize their muscle tone. We want to facilitate flexor activity. Babies are born in physiological flexion. Flexion predominates for a while, and so we want to facilitate that. We don't want to see a child whose arms and legs are kind of splayed out, low muscle tone, not touching their midline. We want to facilitate normal midline flexion, touching the body, things like that. We definitely want to promote that behavioral state organization that we referred to before. We want to give them normal sensory experiences. And again, for a child who's born prematurely, those normal sensory experiences are hard to come by. They're in a loud environment, they're in a bright environment, so we need to manipulate the environment. They're not ready necessarily for a lot of tactile input. Again, they're in an environment, they're within the amniotic fluid, kind of floating around. They're not ready for a lot of tactile experiences, and they get a lot of negative ones in the NICU. You'll see some pictures of babies with lots of tubes and things in them, and so we want to try to help normalize those experiences, sensory experiences. We certainly want to prevent any orthopedic or other types of preventable complications. We want to manage any musculoskeletal issues that exist. And ultimately, we want to help the child transition from the NICU into a home environment in a successful way. So we'll talk about how we're going to do all that. This is just a little summary table, and it gives some examples. It takes 3 of the systems, the autonomic, the motor, and then the state system. And it shows you what it would look like if the baby wasn't doing well, and kind of what our goal would be. So our goal, of course, would be, for example, in respiration, smooth, regular respirations. So during treatment, we may see that the child has excessive or rapid respiration, or that they are gasping or having excessive pauses. So that would tell us that our treatment was stressing the child too much. We want to look at their coloring, which is going to give us an idea of their effectiveness of their cardiac output. From a motor standpoint, again, we don't want to see fluctuating muscle tone or flaccidity or hypertonicity. We want to see nice normalized muscle tone, smooth movements. We want to see normal primitive reflexes like the sucking reflex, hand hold, finger grasp, those types of things. And then finally, we want them to have nice, well-defined pattern between sleeping and waking up. You know, all babies need to get into a rhythm, and we don't want to see them have a lot of trouble with their sleep-wake cycles. And then when they are awake, we want to see them being able to interact and focus and be able to interact with caregivers in their environment. So these are some examples of things that would help us know whether or not we were seeing a stressed or a stable infant in the NICU. So we're going to go on into, we're going to stop this one here, and we're going to go on to part 2, where we'll talk about specific physical therapy interventions.